Good afternoon, everybody. Today we have a pro-con session, and the pro-con session is on inhalation anesthetic agents, what are still called the modern inhalation anesthetic agents. Sevoflurane was introduced in our country sometime in early 2000, while Desflurane was introduced in our country in somewhere around 2007. Since no other agent has come into clinical practice thereafter, the debate continues, whether it's Sevo or whether it's Des. Everybody has his or her own preferences. And let us hear the debate again today. And we will have a pro-con session in which Dr. Ashish Bindra is going to talk about the benefits of Sevoflurane, while Dr. Saikat is going to talk against it and will cite the benefits of Desflurane. To start the debate, I request Dr. Ashish Bindra to give her part of the debate.
Thank you very much, sir. So I have been given to highlight the goods of Sevoflurane, and probably my task is not very difficult. I will share my screen. This is for, the debate is for best inhalational anesthetic agent, Sevoflurane versus Desflurane. Probably my vote goes for sweet Sevo because I've been using it day in and out, and the third generation volatile anesthetic agents, that is Sevoflurane, Desflurane, were introduced in 1990s, as Dr. Saikat is very fond of correlating it with the historical event. So that was the time when Super Mario was introduced by Japanese. The same time, Sevoflurane was used by the Japanese anesthesiologists. And the time when Mars Global Survey was launched, Desflurane was used in American countries. So because of its distinct properties like good blood gas partitioning coefficient for Sevoflurane, Desflurane, and lesser metabolism for Desflurane, more metabolism for Sevoflurane, and MAC of 2 and 6, these agents had some differences, and there is still a controversy which one is best to go for. So the sweet Sevoflurane has been introduced in 1990s, came to India in 2000s, and it is ideal for inhalational induction. It causes minimal hemodynamic alterations. It's widely used in non-cardiac surgery, neurosurgery, ambulatory surgery, and everywhere. And because it is associated with quick emergence and recovery with minimal airway complications and smaller carbon footprint, it is most commonly used as volatile anesthetic agents worldwide. So if we come to the Desflurane, so Desflurane is the one with the pungent odor. It is airway irritant, not suitable for induction, but because of its lower blood solubility, fastest onset and offset, because of difference in blood gas partition coefficients, it had advantages or proposed advantages in outpatient anesthesia, in patients with obesity, patients with prolonged anesthesia, and during low flow anesthesia. And probably I feel these all things have changed over time, and use of Desflurane associated with shorter recovery times and extubation is not more than a myth now. So if we talk about the debate is between the sweet and the pungent. If I talk about 3 P's which are most important to us, we come to the patient, to the planet, and to the purse. So I will talk briefly about all these 3 events, and I will be seeing how Desflurane is not very good as compared to Sevoflurane. So the pharmacology of these inhalational anesthetic agents, volatiles, they are almost similar with some changes where Desflurane causes more drop in blood pressure as compared to Sevoflurane, and some hanky-panky things over the respiratory system and cerebral blood flow. Though there is a long debated research that Desflurane causes an increase in intracranial pressure. Its use is more or less not very common in neuroanesthesia practice, and similar in the cardiac anesthesia practice, wherein their major centers of cardiac anesthesia, probably at institute, also don't have a vaporizer for Desflurane. Then rest of the things are more or less similar. So if we come to the most talked about feature of the Desflurane, then it is early recovery. It results in lesser extubation times and lesser emergence time as compared to Sevoflurane. So there are studies which shows that yes, extubation time and emergence time is faster with Desflurane, but what happens to the recovery time? What are we bothered about? A 2, 3, 4 minutes early recovery from the anesthesia or discharge from the PACU? So this is a systematic review which was published in European Journal of Anesthesiology, which considered 13 trials wherein 634 patients were in the Desflurane group and 633 patients in the Sevoflurane group. And they compared the respiratory complications, which were significantly higher with Desflurane-based anesthesia. There was no difference in occurrence of emergence agitation or incidence of postoperative nausea and vomiting. Time to opening was significantly faster with Desflurane, but yes, there was no significant difference in time to discharge from OR. Mean difference was just 0.45 minutes. So I think it's not worth giving a trial. So why most RCTs are focusing on emergence and extubation favor the Desflurane. So that there is a real world, there is a RCT. In the RCT, till the point of wound closure, the whole anesthetic, it's in its full map is given, but probably in clinical practice, it is not so. So with decrease in the surgical stimulus, we start tapering down the anesthetic agent. And with the tapering down of anesthetic agent, probably the emergence and extubation times won't be very different in the real world scenario. So it doesn't probably result in difference in the turnover time of the OTs. You cannot say that, okay, this is practically good because it is rapid emergence and you can take more number of cases. So it is trivially more rapid emergence. So this is another compilation, a beautiful paper published in Anesthesia 2021, wherein a comparison of postoperative respiratory complications associated with Desflurane and Sevoflurane were used. This is a beautiful study, probably a retrospective one, but it included around 168,000 patients, wherein the primary outcome was postoperative respiratory complications, reintubation within 7 days postoperatively, and secondary outcome was recovery area, length of stay, and also delayed discharge from recovery for respiratory or sedative complications. So now in this study, they have also done a subgroup analysis in morbidly obese, wherein Desflurane has been said to have distinct advantage in elderly greater than 65 years and patients with high risk of respiratory complications. So what did they see? So they saw that postoperative respiratory complications were marginally high in the Desflurane group, though it was not statistically significant. However, the recovery area time, which was statistically significant, was less with Sevoflurane as compared to Desflurane. And recovery area delays, like respiratory sedation, were almost similar in both the groups, though it was slightly more in Desflurane group. So this is their analysis for morbid obesity in elderly patients and high-risk post-op complication patients. In all these patients, there was no significant difference between Desflurane and Sevoflurane. So in patients which are morbidly obese, patients who are elderly, where it had distinct advantages, it's not a very good agent. So now if we come to the other patient aspect, so this is a study, which is another one recently published in British Journal of Anesthesiology, wherein patients with arthroscopic knee surgeries have been enrolled and additional 35 minutes of anesthesia before their operation was given with 1 mAh DES or 1 mAh Sevoflurane. They looked at perfusion index, MAP and heart rate. So it was seen that Desflurane is associated with inferior perfusion, lower MAP. So probably the Desflurane has more vasodilatory potential and it is of magnitude which may cause harm, though these are very preliminary reports and they need to be checked again in clinical setting. This is the time where there is no induction, no presence of the surgical stimulus. So next is conclusion for the patient is, it is not very, very dramatically good agent. Desflurane, Sevoflurane is comparable for out of OR coming out of anesthesia, and recovery time and time to discharge is similar. Discharge from hospital and recovery use is similar, but Desflurane may be associated with higher airway complication and possibility of hypotension. So next comes the pocket. So pocket is another important thing which needs to be seen. So with Desflurane being 1/3 the potent of Sevoflurane, and the cost of each bottle of Desflurane is around 3,000 versus 5,500. It's a bottle print. I saw in the morning in the OR, it is approximately 250 ml of volume. Additionally, Desflurane has some non-drug cost to the healthcare institution, buying a vaporizer, maintaining a vaporizer, training, and all that. So what is the cost analysis? So I saw this paper wherein it is seen that for cases with less than 2 mAh hours, 2% of Sevoflurane at 1 liter and 6% of Desflurane at 0.5, Sevo is far cheaper than Desflurane. And similar for cases where the gas flow was 0.5 for Des and 2 liters for Sevoflurane. But in cases where MAC is more than 2 hours, 1 liter, almost similar cost. For maybe more than 2 max, when your flow is more than 2 liters, there can be a substantial decrease in cost. So now the problem is low flow anesthesia should be used or should not be used for Sevoflurane, because it is associated with cost also and with the environment also. So here this is the editorial from 2019, anesthesia intensive care, wherein it is said it has depicted the survey of Australia and New Zealand Society of Anesthesiologists, wherein Sevoflurane was most commonly used anesthetic, and less than 1 liter was used by 50% of anesthesiologists, and reluctance in not using Sevoflurane at less than 1 liter was probably clinically irrelevant and was present only because of the manufacturing label. And possibly compound A is not nephrotoxic in humans. There is no evidence of nephrotoxicity, and also we have alternated adsorbents which will not result in the formation of compound A. So it is good on pocket. It is better on pocket rather. X is the planet. So it's the environmental impact. So earlier we thought whatever we are delivering because of the healthcare is not substantial, having not carbon print on planet, but no, it is not. Healthcare contributes to up to 7% of total greenhouse emissions, and surgery is part of it. And if we see the global warming potential of these two anesthetic agents, then even at 100 years, Desflurane is there in the environment, and its potential is far more than that of Sevoflurane. So the tropospheric lifetime of Sevoflurane is 1.1 years, where it is 14 for Desflurane. And Sevoflurane is the least damaging volatile anesthetic for the climate. So these are some other figures from the American Society of Anesthesiologists and the British Society, wherein the wider low flow, they have recommended for green anesthesia for minimize the uses of the Desflurane. So Desflurane modern anesthetic practice, as it is said in an editorial by Shelton et al. For BGA 220, is like walking on thin ice tabs. So there is no superiority of Desflurane over Sevoflurane. Rather, Sevoflurane is far superior because it's safe for the planet, it's easy on the pocket, and it is also good for the patient. So here I rest my case, and I think Sevoflurane is the people's choice, and it should win the debate because there is no comparison between Sevoflurane and Desflurane. Thank you very much.
Thank you, Dr. Ashish. We now go for the con side, and let us hear Dr. Saikat put his case forward.
Right, sir.
Thank you, and I hope my slides are visible and I'm audible.
Yes.
And I take this opportunity to thank ISACON Kerala, Dr. Sajeesh, Dr. Venkatagiri for letting me debate on the best inhalation maintenance agent and whether the agent of choice is indeed Desflurane. But the operational word is inhalation maintenance agent. We know about what are the phases of anesthesia. For the point of the debate, we should be focusing on maintenance and along with it, the recovery, so that you cruise through maintenance, have a very safe recovery, and at the end point, you have an appropriate endpoint of the surgical or the interventional procedure. And coming to, in the context of or the automobile industry, I call, and we all started our life with Halothane, the ambassador Halothane, then we came to the Maruti 800 Isoflurane, and today most of us have the luxury of using Sevoflurane and Desflurane, and I compare it with the Merc, with the Ferrari. And to the context of the debate, we are now talking about Sevoflurane versus Desflurane as a maintenance anesthetic agent, and with an overall goal so that you not only have the patient unconscious, unresponsive with a safe anesthetic depth, but maintaining the internal milieu And you can have various techniques, but the point that we are talking about is this balanced general anesthetic technique with the inhalation agent, not just the primary inhalation technique. And the ideal anesthetic agent for maintenance should have, therefore, a rapid onset of action with minimal side effects, and very importantly, cleared quickly from the bloodstream to ensure a rapid recovery. And the ideal anesthetic maintenance agent, which was put forward by Savares many years back. But if you look through this, the bones of contention, again, and I come to the maintenance anesthetic agent will be the low solubility in blood and tissues, the resistance to physical and metabolic degradations, and the lack of propensity to cause certain side effects. And how do these agents fare vis-a-vis this? Vis-a-vis the partition coefficient, we know about this, isn't it? A low blood gas partition coefficient, a low tissue gas partition coefficient are desirable properties because you have a more precise control over the anesthetic state and the rapid recovery from anesthesia. And if you put them into the numbers, what your pharmacologist tells you, your textbook tells you, Desflurane scores much better over Sevoflurane. And here, the lesser the number is, or the lower the number is, it's better, isn't it? Because it kind of correlates, or definitely correlates, with rapid uptake and also rapid clearance and emergence. And also importantly, a low oil gas coefficient will decide on how much is the uptake on the adipose tissue, and therefore is particularly advantageous in patients who are at high risk, the morbidly obese, people with sleep apnea, elderly, etc., etc. We are not just talking about simple ASA physical status 1 and 2. It is this high risk group, and in this, which is possibly a better maintenance agent. And in this regard, I think nobody doubts that Desflurane has the lowest blood and tissue solubility coefficient among the potent volatile anesthetic agents. What does this correlate to real life scenarios? Well, we talk about the patient being conscious. In this regard, it is about decrement of the inhalation agent up to around 80% in the vessel reach group. Okay, they are kind of nearly similar, but what separates the men from the boys is recovery, which is determined by the normalcy of pharyngeal function, which is around decrement of around 92% in the vessel ridge group. And it is here that Desflurane, as you can easily figure out, is far superior to Sevoflurane. And this slow compartment accumulation, predictable recovery, relates to rapid transfer of patients from the operating theater to the recovery area and into patient turnover. There have been people who of late have been trying to say that, well, you can decide when to switch off, how to let the inhalation agent kind of decay over time and play with your flows. But that, if you again scan through literature, will come at the cost of using certain IV anesthetic agents, at the cost of using additional narcotic agents, which might also influence your recovery times. In the end, it has also, this low flat solubility also not only determines your operating room time, but also minimizes the stay in possibly the high dependency area, because you'll figure out the early things which will come to is much better with Desflurane versus the Sevoflurane group. Let's now look at certain evidence. And this is one of the classic papers which we all read, and I think still holds good even in the wake of certain publications which have appeared over the last couple of years. And this, why I like it, is because they looked into various BMI groups, compared the two head to head, and looked at not only recovery of consciousness, but also recovery of anesthetic airway recovery. And what did they find? And people have not disputed this study as yet, that the longer time of anesthetic discontinuation to airway reflex recovery is related to the BMI, and Sevoflurane fares far worse than Desflurane, 28 seconds per kilogram meter square for Sevo versus just 7 seconds per kilogram meter square for Desflurane. And the airway reflux recovery was far, far predictable in Desflurane. Again, nobody disputes this even today. And this is even more accentuated in the patients with the higher BMI group. Come to this as well, the longer you use these inhalation agents, Sevoflurane starts faring even worse. And the delay in recovery with Sevoflurane increases by nearly 4.5 minutes per Mach hour, whereas it is just, if you look at the graph below, it is just a straight line for Desflurane, which is 0.2 minutes per hour for every Mach hour. So the thing, even despite several publications after the Mackay publications, this stays steadfast. That prolonged Sevoflurane administration, greater BMI delays airway reflex recovery, and the contribution to the BMI to this recovery is more pronounced after Sevoflurane than Desflurane. Elderlies greater than 2-hour surgeries, again, early recoveries is far affected with Desflurane than Sevoflurane. Obese coming in for neurosurgeries, and this is for Ashish. I think she will not dispute this, being a neuroanesthetist herself, the Pinocchio group. And again, this has not been disputed even till date, that the short orientation memory in the beginning, say the 10, 15, up to 20 minutes is better with Desflurane. The cognitive recovery is far better, again, in the first 15, 20 minutes with Desflurane. It's after 20 minutes that they start equalizing. By this time, you should be having an ability to kind of discharge your patients outside. And also with the physiological variables and the motor variables, Desflurane does much better even in this group vis-a-vis PaCO2 pH, their recovery after the surgery is over. And I think the list does not end here. If you scan literature, you will find it in not only OBs, in not only neurosurgery, but also possibly in gynecological surgeries, daycare procedures, with endotracheal tubes, with laryngeal masks. Airway reflexes recovery is far, far better with Desflurane. And airway reflex recovery is the thing to look forward to when you're talking about recovery after an anesthetic agent. So coming back to the analogy of the motor carts, whether it's a long, long drive and with bends and tricks, or it's a bad, bad road that is bad, bad patients, or it's a slippery road, and you want to come to a good final point of destination without getting off the road, safe and efficiently. And if you'd like to try and then compare between the two agents, the evidence solidly is heavier in the favor of Desflurane. And if you look at even the meta-analysis, looking at recovery after a prolonged anesthetic, or even with a anesthetic even less than 2 hours, Desflurane reduces the average extubation time and the variability of extubation by nearly 20 to 25% relative to Sevoflurane. And this has bearing. It reduces your OR time, it reduces your PACU times, it reduces delays, and the esteem of an anesthesiologist improves because you're improving the efficiency and the functioning of your institution. So beware of that. And if you put further scanner into these agents, you'll figure out that metabolism, Desflurane undergoes the least metabolism of the potent volatile agents. So organ function does not matter when you're using this. Resistance to degradation. Well, we have been hearing from our student days about compound A that it's being nephrotoxic in animals. possibly in humans. Yet today, nobody says no in humans. And if you unfortunately land with a desiccated absorbent, there is always a risk of fire, which has also been reported. And despite people saying that it is only because of the product insert, the product insert started coming early 2000. Even today, the product insert will tell you that if you are using for more than 2 Mach hours with a flow rate of less than 2 liters per minute, beware of proteinuria and glycosuria. So they are hinting at the nephrotoxicity, and they're telling us categorically that it is wiser not to use a flow rate of less than 1 liter per minute. So it will take a lot of guts because there is no categorical evidence as on date to suggest that you can easily use it. With seizures, yes, there is a risk. Sevoflurane, especially in those with baseline risk of seizures, is definitely not the agent of choice. Respiratory irritation with Desflurane. Mind you, this is a concern if you are using it for induction. Today, we are debating about a maintenance inhalation anesthetic agent. And if your maintenance anesthetic agent is it doesn't actually have any bearing, and even then it doesn't have any bearing if the threshold Mach is less than 1. About circulatory stimulation, again, if you are only trying to increase it too high, too quickly, then it becomes an effort. So it doesn't matter what car you are given, but you also need to know how you need to drive that car, isn't it? So, and you can also attenuate it with the help of agents like a narcotic fentanyl. So if I finally put it to verdict and even possibly ask for an audience poll, I think Desflurane is the superior agent for maintenance by a big, big margin because of its very low blood gas partition coefficient, low oil gas partition coefficient, ability for rapid clearance and emergence, and particularly advantages in the high-risk population, the morbidly obese elderly, rapid turnovers, even after long duration procedures or short duration procedures. And this is a big thing about quality and safety in anesthetic practice today. And if about also economics, is still the safer drug to be used in low fresh gas flow systems. Thank you for a patient hearing.
Thank you, Saikat. It was wonderful to hear you again. And, I'll go to the rebuttal side now, and I'll ask Dr. Ashish to rebut what you've said. But before, Dr. Ashish, before you rebut, let me be a devil's advocate and let me put some more problems to you. You mentioned that in neurosurgery and cardiac surgery, the Sevoflurane is preferred. Yes, I agree with you on 100% on that. The reason is not being a cardiac anesthetist myself, but you being a neuroanesthetist, you would understand that recovery, immediate recovery is not important in cardiac surgery and neurosurgery. In cardiac surgery, we need to ventilate the patients post-operatively for some time. In neurosurgery, as it is because of the brain getting in the surgery, if the brain is there, you've done surgery, they are a little not very clear in their mind as in the brains also at that time. So probably this is one thing where Sevoflurane, I don't think that should be the reason, but that is the reason why Desflurane is probably avoided. So let's hear your rebuttal about what Saikat has told you.
Right, sir. So as Dr. Saikat said, today's era of balanced anesthesia. So whatever he proposed for the rapid recovery times, possibly can be easily achieved with the use of Sevoflurane with balanced anesthetic technique. I quoted evidence for use of Desflurane in morbidly obese patient and prolonged duration of anesthesia, wherein yes, there is a controversial literature wherein it is said that if you do a MACE test, you do this test, that, or post-operative cognitive delivery dysfunction assessment, then probably literature is slightly favoring towards Desflurane. But as such, the transfer of patient, transfer to the post-anesthetic care units, they are surely better or comparable sevoflurane versus desflurane. So all the clinical trials, I already told that they are using MAC till the end, and that is why probably that's recovery and extubation is an issue with those trials. And but major evidence says that post-anesthetic recovery from the ICU PACU transfers are better with sevoflurane or comparable between the two agents. So maybe yes, in morbidly obese, there may be a slight variation. Then again, if you talk about long procedures, then long procedures are the cardiac surgeries and the neurosurgeries, wherein probably a 5-10 minute recovery delay won't be that big factor. Then next, as concerned to extubation and emergence time, my stand is that we can do well with balanced anesthesia, and probably sevoflurane can render similar results as desflurane. So now the next is for Sir said that compound A formation. Yes, there is a trivial possibility. So if it was said that halothane causes hepatitis, it was evident. So if people say that compound A is formed, there should be at least one case report of saying that, yes, it's causing formation of compound A or something, nothing appeared in literature. And in 1996 itself, the Australian New Zealand Society, pharmaceutical companies, they removed this label of less than 2 liters from the sevoflurane. I agree that it exists on most of the bottles, but I quoted a survey of few anesthesiologists across the world which are using sevoflurane for less than 1 liter per minute, and probably there are no reports of toxicity. And the compound A, as such, written in textbooks that it is nephrotoxic in rats, and I don't know the human data exists or not. And if we try off dry desiccated soda lime, then we have possibilities of carbon monoxide production. And these are all probably, I won't say you should not use desflurane because it causes this. So these are trivial things which probably don't matter in clinical trials. And then about the degradation, if people say that sevoflurane is getting metabolized, so it is not staying in environment also. So it's probably very safe planet-wise. And there are recommendations, there are evidence which is coming up, which is saying that we should not use desflurane because it is staying there in the atmosphere for as long as 14 years, and global warming potential at 100 years is possibly the most with this anesthetic agent. So if we have a replacement, and if we are using sevoflurane very often because it was introduced into Indian markets earlier and people were happy, satisfactory. So many centers are not even having desflurane. Many major centers are not having desflurane because probably they did not feel the need of this agent. It is not just absence or ignorance. It is because they found that they were pretty happy with sevoflurane. Why to change for no good reasons? So I still stand with the use of sevoflurane for people, pocket, and planet.
Thank you, Dr. Ashish. Now, so again, devil's advocate for Saikat. Saikat, thank you. Saikat, this is about compound A. Compound A, I think, is overhyped, definitely. I would agree. And because all over the all European countries today, they do not believe in the compound A problem, and they are sort of permitted low flow anesthesia with sevoflurane. Unfortunately, the US FDA has still not approved of it, and that is why the insert still has it. And that is the reason why it has it. There's no other reason. As far as the environment is concerned, I think, again, it's overhyped. I'm going against Ashish, what you're saying. It's overhyped. Anesthesia hardly contributes to pollution. And inhalation anesthetics are such minute quantities. These are mathematical models which were proposed by some scientists, and it has been overhyped. I think we are overhyping it, and the trade tries to hype it even more about environmental degradation. Inhalation anesthetic or anesthesia per se hardly contributes to pollution. Anyway, Saikat, let's hear what you have to say about everything.
I think you got it right. I think the overhype bit about both, and but the thing is, whether it is overhyped or not, at the end of it, if you land up with a problem, and if you land up with a problem and it is something you did despite the producers or the manufacturers telling you not to do it, there is hardly anything that you have in defense. And if you look at it, if you're looking at the defense, if I'm talking about from my context, from my scenario, my societies, the Indian society has not come out with a kind of user guideline for the use of this agent with flows below 2 liters per minute. So, all said and done, if it comes with the product insert which says that there is a distinct possibility of nephrotoxicity, so be aware of glucosuria, be aware of proteinuria, I would be a little hesitant when I have a person on table who has renal compromise, despite the fact for all the evidence that you can show me about saying that there has been hardly any difference in large randomized trials. You won't have large randomized trials head to head. So it has been a kind of extrapolation of few trials and then put together as a meta-analysis. So, you will have to again take it with a pinch of salt for all those data that comes out from the meta-analysis of head to head about agents where you really have paucity of data with RCTs. Regarding Dr. Ashish's contentions about triviality, I think today we need to take care of the trivial matters a little more strongly than possibly we do. Because if you look at the other issues that used to be bones of contentions in anesthesia practice, maybe 20 years back, maybe 25 years back, those have been reasonably well stabilized. And it is now that we need to look at trivial matters, like even 10-15 minutes might matter in recovery times when you're looking at an operating room list which runs into 15s and 20s per day. And if you multiply 15 into 10, and I'm talking about the duration of surgeries which are not greater than 2 hours, and this again a data which has not been contested by anywhere else about the recovery time. And even if you are allowing agents to coast, this is one of the contentions that people have about if you let the inhalation agents to coast, then you possibly can reduce recovery time. But again, this has not been shown in a categorical way in any of the trials that at least I have gone through. So if you can, even if 5 minutes or 10 minutes matter, it is no more trivial. I think that is something that we need to lay importance on and take it seriously, because at the end of the day, you possibly do more lists in your operating room. You possibly have a safer person with vis-a-vis the airway when they go to the recovery, and possibly you can send them to the high dependency areas and not necessarily in the intensive care areas. I'm talking about major oncosurgery, major head and neck oncosurgeries where you're really bothered about the airway reflexes. And it is here that I would be more comfortable when I am more assured with airway recovery, immediate as well as intermediate, vis-a-vis these two agents. Regarding like cost, I think as of date, the acquisition cost between the two agents are, I think, very, very similar. The acquisition cost of the vaporizer is not a factor, because all vaporizers are today given by the producers themselves, the manufacturers themselves. And secondly, if again, though I know there are people who would use flow rates as low below 1 liters, but I would be hesitant to use flow rates possibly below 1.5 liters or possibly 2 liters for Sevoflurane, whereas I easily go down to flow rates around 0.6, 0.7 with Desflurane. So in the end, and if you're looking at longish duration, then again, the acquisition cost between the agents is not a factor at all. So I would still say that in the high-risk population, obese population, in the elderly population, in patients with organ dysfunction. Possibly the agent to look forward to for maintenance is Desflurane. For rapid turnovers, for shorter operating room recoveries, for shorter PACU recoveries, for possibly the ability to avoid even intensive care and go to high dependency units. The third point could be put to debate again, but for the first two, I would still think my agent of choice would be Desflurane.
Thank you, Saikat. Saikat, I'm a big user of Desflurane, and I use it at very low flows. I use it at less than half liter always. You can never more than half liter in my OT ever. And I use low flows with Sevoflurane. So whenever I use it, it is not that I don't. I use the same flows with Sevoflurane, and that's why I say it's a big hype.
Yeah.
And one very important thing which I have learned over the time is, if you are monitoring your inhalational concentrations well, end-tidal concentrations well, and you ensure that your drug, the agent concentration is around 0.1 MAC or 1.15 MAC at the time of extubation, your patient will not have any post-operative problem. I never give oxygen supplementation to my patients immediately after extubation. They don't need it. But it's very easy to achieve that with Desflurane, very difficult to achieve that with Sevoflurane.
Yeah.
That's one major difference. But this debate can go on forever, and we can't go on this. So what we will do is, now we'll have to go in for audience questions and let the audience also participate and give us their point of view, and we continue there. Thank you.
Thank you, Dr. Ashish. Thank you, Dr.
Thank you, sir. Thank you, Mukul, sir. Thank you, Saikat.
I hope there's some questions from the audience. I can see the chat box, which is absolutely empty. No questions as of yet. If anybody has any questions, you can please put it right now.
Yeah. I think before anybody rebuts, I think I have a disclaimer. I think this was for the purpose of a debate, and I was speaking for Desflurane, and that does not necessarily mean, at least to me, that that is the only inhalation agent that I use. So that's a disclaimer. But for the purpose of the debate, I would stick to Desflurane.
Yeah, everybody uses everything. I'm quite sure, Saikat, that everybody uses everything. And for debate, it is an academic thing actually that you do.
An academic exercise. Yeah.
Points of every agent.